So Dr. Andrew Clamp is a consultant and honorary senior lecturer in medical oncology at the Christie NHS Foundation Trust and the University of Manchester. He specialises in the treatment of gynecological cancers. Dr. Clamp leads the gynecological cancer clinical research team at the Christie and is the chief investigator for the international ICON 8 trials programme in ovarian cancer and the phase 2 Copelia trial for recurrent endometrial cancer. So we're delighted to have you here with us, and thank you so much.
Thank you, Anna, for such a kind introduction. Thank you for asking me to speak about what really is a new era we're entering into in the systemic treatment of endometrial cancer, with the incorporation of targeted treatments that are really going to improve the outcomes for our ladies with advanced or recurrent disease. So these are my relevant disclosures. So the clinical trial work I'm going to talk about today is really built on the improvement in our understanding of the molecular biology of endometrial cancer that's happened over the last 10 years, following on from the publication of the TCGA analysis of endometrial cancer a decade ago now in Nature, where they were able to divide endometrioid and serous endometrial cancers up into 4 distinct molecular subtypes shown on this graph: poly, ultramutated, microsatellite, unstable or hypermutated disease, copy number low and copy number high, which had distinct biological phenotypes and clinical behaviour, and offer really some understanding about what novel therapeutic targets there might be that we could exploit to treat endometrial cancer. So we know these 4 categories have distinct prognoses, and that varies from excellent prognosis for tumours which have got poly mutations, down to very poor prognosis for those tumours that are copy number high or serous like disease, which are generally characterised by p53 mutations, and, as I say, copy number abnormalities that mimic sort of homologous recombination repair deficiency that we see in high-grade serous ovarian cancers. And this opens up potential therapeutic avenues that have been explored. So poly and MSI high endometrial cancers both have high levels of tumour mutations and neoantigens, and are so sort of potential therapeutic targets for immunotherapy, whereas, as I say, copy number high may have the biological abnormalities, which means that we can exploit PARP inhibitors like we do in high-grade serous ovarian cancer. And we can now take this molecular classification through into the mainstream in our clinics using a simple panel of molecular tests that was developed on the back of the PORTEC-3 study, where they used immunohistochemistry for p53 and mismatch repair proteins and DNA sequencing to look for mutations in the exonuclease domain of the poly gene to define the 4 categories that were found in the TCGA. And they were able to replicate those results and show that these categorizations were indeed associated with distinct prognoses, but also that they were predictive of the benefit from adjuvant chemotherapy treatment, which has led to us really confining our use of adjuvant platinum-based chemotherapy to patients who've got p53 abnormal cancers or more advanced stage tumours with no specific molecular profile. So before I go on to talk about the sort of the newer drugs that are coming through, I think it's appropriate to sort of reflect a little bit on what we were able to achieve with chemotherapy, really up to just the last couple of years. So our first-line standard of care treatment for advanced or recurrent endometrial cancer has been carboplatin and paclitaxel chemotherapy, with a response rate of just over 50% and a median overall survival of about 2 years. There's never been a worldwide defined second-line cytotoxic treatment. Many centres internationally would use either single-agent doxorubicin or Calyx or weekly paclitaxel. And we know that response rates to these treatments after failure of carboplatin-based treatments are low at 15 to 20%, and overall survival is less than a year. In terms of much older targeted therapies, we know that endocrine treatment particularly high-dose oral progestogens, can be helpful in a selected population of patients with low-grade hormone receptor positive, predominantly low volume disease. And a minority of these ladies will get very durable responses to treatment. But for many ladies, when they develop advanced or recurrent disease, their prognosis is poor and only measurable in a small number of years. So as I said, immunotherapy is a treatment modality that's now been explored extensively in endometrial cancer. It was named the breakthrough of the year 10 years ago in the Science journal due to significant improvements in overall survival that was seen in melanoma and renal cell cancer. And the way this treatment works is we know that our immune system, particularly our T cells, are constantly surveilling our body, looking for cells that are carrying abnormal proteins, what we call neoantigens on the cell surface. And many tumour cells express these neoantigens, and they're particularly high in endometrial cancers that, as I say, have got either a polymutation or mismatch repair deficiency. And normally that would result in T cell killing off those cells expressing the abnormal antigens. But many tumours have high levels of receptors on the surface, which we call checkpoint inhibitors, which bind to receptors on the T cell and prevent T cell lysis of the cell, resulting in immune tolerance of the cancer cells. We've now developed a class of drugs, predominantly monoclonal antibodies, which block and inhibit these checkpoints and re-stimulate the immune system, the T cells, to attack and eliminate tumour cells. And as we shall see, these have proven to be extremely effective therapeutic agents in mismatch repair deficient endometrial cancer. And the first of these drugs, which is now entered routine practice in the UK, is dostarlimab. And that was based on the results of the Garnet trial, which unusually for practice-changing trials was a phase 1 trial, which had some disease-specific expansion cohorts. And what I'm going to talk about here are the 2 cohorts that were performed in endometrial cancer. So these recruited women with recurrent endometrial cancer whose disease had progressed after platinum-based chemotherapy. They had measurable disease and were of good performance status. And there was a mismatch repair deficient disease cohort with just over 150 patients, and a cohort of women who had mismatch repair proficient disease. They were treated with dostarlimab once every 3 weeks for the first 3 doses, and then 6 weekly until disease progression or toxicity. And what this study showed is that the response rate in mismatch repair deficient endometrial cancer was much higher than we've seen with conventional cytotoxic treatment at 45%. There was a response rate in mismatch repair proficient disease, but that was substantially lower at 15%, and that was predominantly confined to the small group of women who had polymutated recurrent endometrial cancer. And importantly, the response that was seen was much longer in patients who had mismatch repair deficient recurrent endometrial cancer. And this is shown here in the swimmer's plot from the trial. And in those nearly 50% of patients who did respond, 84% of those had a response that lasted at least 2 years. And when the latest analysis of the trial was published just last year, the median overall survival in patients with mismatch repair deficient endometrial cancer hadn't been reached, and 3-year overall survival was just under 60%. We've seen similar results with pembrolizumab, and this is again a phase 2 single-arm trial that was conducted with pembrolizumab in patients with recurrent mismatch repair deficient endometrial cancer, and it showed amazingly similar response rates, 48%, and again extremely durable responses with a 3-year overall survival of 60%. And again, that has led to pembrolizumab gaining nice approval last autumn. But these new drugs with a distinct mechanism of action have got distinct side effects. There's a distinct toxicity spectrum that we need to learn to manage, and that's because of the activation of the immune system particularly T cells in non-tumour tissues. And this causes sort of an inflammatory toxicity spectrum, which can impact any organ system, as shown by the figure on the left, and it can mimic autoimmune conditions. Now, most commonly, we might see mild toxicities like skin rash or easily treatable toxicities like hypothyroidism, but less commonly we can see significant immune-related events such as hepatitis, pneumonitis and enterocolitis, which can really cause very significant problems for our patients and require high-dose steroids to treat. But for many patients, these treatments are well tolerated. And what we know that in the Garnet trial and the pembrolizumab trial that I've mentioned, it was less than 10% of patients had to discontinue treatment because of an immune-related adverse event. And the ones that most commonly led to treatment discontinuation were pneumonitis or hepatitis, and less commonly colitis and other endocrine toxicities. The really very exceptional activity we've seen with immunotherapy in recurrent disease setting, in terms of managing adverse events, it's really important that we are aware of the guidelines that are available from our international societies. And the ones that we use specifically at the Christie is the ESMO clinical practice guideline. And it's also important to develop sort of an algorithm within the team to try and manage these toxicities. And the most important thing is really to make sure that both the patient and the team are well educated about what the potential side effects may be, how to anticipate these side effects by screening, close history, close monitoring, and also being able to identify and treat those toxicities early. And on the left-hand side, we can see a simple algorithm that's been developed by the team at the IGR Centre in Paris, which is really helpful in terms of assessing how we may manage these side effects in our patients receiving immunotherapy. So moving on, following those exceptional results that were seen in patients who'd received platinum chemotherapy, there have been a series of trials that have been conducted bringing immunotherapy forward into the first-line setting and giving it alongside platinum-based chemotherapy. And 4 of those trials were presented last year. The most important one to inform current clinical practice imminently is the Ruby trial, which recruited patients with primary advanced or recurrent endometrial cancer. And they were randomized to either receive carboplatin alone or carboplatin with dostarlimab sequentially with chemotherapy, and then continuing for up to 3 years. The trial was designed to look at progression-free survival in the overall population, but also specifically in the population most likely to benefit the mismatch repair deficient patient group. This is the Kaplan-Meier curves for the overall population. And as you can see, there was a significant improvement with treatment with dostarlimab compared to those patients who had chemotherapy alone, with an 18% improvement in progression-free survival at 2 years. But if we look in more detail and we look at those patients who had mismatch repair deficient compared to those patients who had mismatch repair proficient disease, we can see that the benefit was much larger in those patients with mismatch repair deficient disease. 2-year progression-free survival increased from 15% with those that just had chemotherapy to over 60% with those that received dostarlimab, and they had a 72% lower chance of their cancer progressing on treatment. And the benefit in the mismatch repair proficient population was much smaller. And this has led to dostarlimab being licensed for patients with mismatch repair deficient advanced endometrial cancer alongside chemotherapy treatment. Alongside the presentation of the Ruby results, we also learned the results of a similar trial that was looking at pembrolizumab alongside chemotherapy treatment, the NRG GY018 trial. This was results were reported with a much shorter follow-up of a year compared to just over 2 years for Ruby, but they reported very similar results with a significant and a large improvement in progression-free survival for those patients who had mismatch repair deficient disease, and a much smaller improvement for those who had mismatch repair proficient endometrial cancers. The other important trial that was presented last year was the DUO-E trial, which, as well as incorporating immunotherapy, also incorporated a PARP inhibitor, so olaparib, in one of 3 treatment arms. And the reason for this, as I said, is that because those patients that have p53 mutant disease do have genomic changes that are similar to what we see with homologous recombination repair deficient ovarian cancers. And there's also evidence to suggest that PARP inhibitors may enhance the activity of immune checkpoint inhibitors. So in this trial, patients with advanced or recurrent endometrial cancer were randomized to 3 arms. In the first arm, they got carboplatin and paclitaxel chemotherapy alone. In the second arm, they received immunotherapy with a drug called durvalumab, which again is very similar to dostarlimab and pembrolizumab, alongside chemotherapy and then as maintenance treatment. And in the final arm, as well as receiving the durvalumab, they also received maintenance olaparib once they'd completed their chemotherapy treatment. And what we saw in this trial is that there was an improvement in progression-free survival with both of the arms incorporating immunotherapy treatment. In the overall population, there was a very slightly greater improvement in disease control with the arm that received durvalumab and PARP inhibitor maintenance. But when we look at that on the basis of the molecular grouping, in those patients who had mismatch repair deficient disease, there was a very marked improvement in progression-free survival in both the immunotherapy containing arms, but there did not seem to be an additional advantage from receiving olaparib alongside the durvalumab. In those patients who had mismatch repair proficient disease, however, there was a significant increase in progression-free survival on the arm that had durvalumab and olaparib compared to the arm that received durvalumab alone, suggesting that the combination treatment may be more effective in this group. And certainly we're awaiting, I think, longer-term overall survival data from this study to really see whether the combination treatment may become a standard of care treatment option for our patients with mismatch repair proficient recurrent endometrial cancer. So where are we with immunotherapy currently? Well, it's clearly been a major advance in the treatment of patients with mismatch repair deficient recurrent disease. As I said, it's been recommended by NICE for the treatment of recurrent disease after platinum-based chemotherapy. And the outcome of their appraisal for the first-line use of dostarlimab plus chemotherapy is imminent, and we're expecting the draft guidance next week. But there are some real key clinical research questions that we need to answer. So firstly is, do we actually need the carboplatin and Taxol chemotherapy for patients with mismatch repair deficient disease? And there are trials that are ongoing and should be reporting in the next couple of years that will answer that question. Secondly, can we use immunotherapy in the adjuvant setting to actually prevent disease relapse? And again, those trials are ongoing. And then thirdly, how do we overcome resistance in the group of patients who don't respond to immunotherapy or progress on treatment? And how do we widen the activity of immunotherapy outside of patients with mismatch repair deficient disease? So I just wanted to highlight the Rainbow trial, which is an international adjuvant study looking at molecularly directed adjuvant treatment. And that has 4 trials incorporated within one large study, with entry into those studies dependent on which of the 4 molecular subtypes the patient's tumour falls into. So if the patient has a p53 abnormal endometrial cancer, their adjuvant treatment is randomized between standard chemoradiotherapy or chemoradiotherapy followed by maintenance olaparib. If the patient has mismatch repair deficient disease, their adjuvant treatment is randomized between radiotherapy and durvalumab, so immunotherapy. For patients who have no specific molecular profile, and this is the trial that's being led from the UK, those patients are randomized either to receive chemoradiotherapy or radiotherapy plus progestogen therapy. And for those patients who have polymutant disease, the plan is to conduct an adjuvant study looking at outcomes with no adjuvant therapy or de-escalation. So looking at widening the efficacy of immunotherapy, I'm sure you're all aware of the combination treatment of lenvatinib and pembrolizumab, which we're using beyond platinum for our patients with non-MMR deficient cancer. And this was based on the results of, as I say, the Keynote 775 trial, where patients with advanced recurrent endometrial cancer who'd failed platinum-based chemotherapy were randomized either to a combination of lenvatinib and pembrolizumab or investigators' choice chemotherapy with either doxorubicin or weekly paclitaxel. So lenvatinib is an oral drug. It's a multi-targeted tyrosine kinase inhibitor. Its main mechanism of action is to inhibit angiogenesis through blocking vascular endothelial growth factor receptors. It has a distinct side effect profile, hypertension and proteinuria, which are side effects that I'm sure you're used to from giving bevacizumab in ovarian cancer, but it has wider side effects from some of the other off-target kinases that it inhibits, particularly diarrhea, hypothyroidism, and fatigue. And what this study showed was that in patients with mismatch repair proficient recurrent endometrial cancer, the combination of the two novel drugs extended overall survival and increased median overall survival by 5.8 months, from 12.2 months to 18 months, with a doubling in response rate during treatment. But the addition of lenvatinib to pembrolizumab comes with a significant toxicity burden. As you can see from this slide here, the majority of these patients do develop significant toxicities, often very early on treatment. And as clinicians and as patients, we really need to be aware of these toxicities and educated on how to manage hypertension, musculoskeletal disorders, and the GI side effects predominantly that we see with treatment. And this significant toxicity profile really confines us using this treatment to patients who have good performance status with well-controlled and minimal comorbidities. So finally, I just wanted to do a bit of horizon scanning and look at a couple of areas which I think are really promising in terms of drugs in early phase trials currently. So I want to talk about antibody drug conjugates, but also an exciting drug that might be very useful in p53 wild type endometrial cancer. So antibody drug conjugates are a novel immunoconjugate made from a monoclonal antibody that binds to a cell surface epitope that's overexpressed specifically in a particular cancer type, which is attached to a cytotoxic payload by a linker, which is cleaved when the antibody is bound to its target. There are multiple antibody drug conjugates in clinical development and also in trials in endometrial cancer. And the three most promising antigens they're targeting are HER2, TROP2, and the folate receptor alpha. So these drugs do have their own particular toxicity profile. So a lot of that is dependent on the cytotoxic drug, so the chemotherapy drug that they're delivering. So we do see hematological toxicities, neurological toxicities, because a lot of these drugs are similar to vinca alkaloids and paclitaxel and can cause sensory neuropathies. But many of these drugs are also associated with interstitial lung disease, possibly because these antibody drug conjugates get filtered out in the capillaries within the lung alveoli. Just as an example, the most promising target at the moment in endometrial cancer is targeting the HER2 protein. So this is overexpressed in somewhere between 20 and 40% of endometrial cancers. The highest instance of overexpression is seen in serous cancer. About 5 to 10 years ago, there was a trial conducted in the US looking at Herceptin, so trastuzumab, and this was a randomized trial in patients with HER2 overexpressing advanced or recurrent serous endometrial cancer. And those patients received chemotherapy with or without trastuzumab. And what the trial showed is that there was a significant improvement in progression-free survival and overall survival by the addition of trastuzumab. And this has led the NCCN guidelines in the US to change to incorporate trastuzumab as a potential option for the management of recurrent serous HER2 overexpressing endometrial cancer, although that's not a drug that's available to us at present in the UK. But interesting, it's led to further studies looking at antibody drug conjugates based on trastuzumab. And I wanted to just mention the results of the Destiny trial that were published earlier this year and focus on the 40 patients with endometrial cancer that went into this study. So these patients had been heavily pretreated with prior chemotherapy, and they had HER2 overexpressing tumours. And what the study showed is that the response rate to this new drug, trastuzumab deruxtecan, was extremely high. So it was 57% in all comers and 85% in those patients who had HER2 3+ overexpression, so the highest levels of HER2 on the cell surface. And the responses to this drug were really very durable. However, 10% of these patients did develop interstitial lung disease, which required treatment discontinuation and high-dose steroids. And overall, in the whole trial across all tumour types, there was a 1% incidence of fatal lung toxicity. So really, again, an important toxicity that we need to be aware of. This drug and similar drugs are entering randomized phase 3 trials in endometrial cancer this year. And if those are positive, will likely become part of our standard of care armamentarium within the next decade. So finally, I just wanted to mention a promising drug in p53 wild-type endometrial cancer. So obviously this mainly includes those patients with no specific molecular profile disease, which is, as I say, is underrepresented in the trials that we've mentioned previously. And the promising drug is a drug called selinexor, which is an exportin-1 inhibitor. So exportin-1 is a transmembrane protein within the nuclear membrane, and it's responsible for the nuclear export of multiple proteins, including p53. We know that when this is overexpressed in cancers, it's associated with poor prognosis. But if we inhibit this transmembrane protein, it leads to the nuclear accumulation and reactivation of tumor suppressor gene proteins, including p53. And it's a drug that's already licensed in several hematological malignancies. There was a phase 2 trial that was conducted in endometrial cancer that had responded to first-line chemotherapy, where patients were randomized to take this new drug, selinexor, once a week orally until disease progression, or to take a maintenance placebo. About half of the patients who went into the trial were p53 wild type, and half of patients had p53 mutated disease. And what the study showed is that in the overall population on the left, selinexor was associated with a small, not statistically significant improvement in progression-free survival. But if we look at those patients who had p53 wild-type disease, the benefit from treatment, perhaps unsurprising, looks substantially greater, with median progression-free survival improving from 5.2 months to 13.7 months. This is a drug that's relatively well tolerated, although it does cause nausea and thrombocytopenia, but about 50% of patients in this trial did have some degree of nausea and vomiting. So a confirmatory randomized phase 3 trial is now underway looking at selinexor at a slightly lower dose as maintenance treatment in p53 wild-type endometrial cancers, and we're likely to see the results of that presented in the next 2 to 3 years. So in summary, the last few years have really been a time of rapid improvements in the systemic therapy of endometrial cancer. We're now routinely incorporating targeted treatments, i.e. immunotherapy, into our management of patients with mismatch repair deficient disease. And that's been driven by our understanding of the molecular biology of endometrial cancer, and also extrapolating from other disease sites, particularly with results of trastuzumab that I've discussed. These novel treatments are increasing the survival of our patients with advanced and recurrent endometrial cancer, and often maintaining and improving quality of life. But it needs very close collaboration to incorporate these drugs into our management between oncologists and many other of our colleagues, particularly our histopathology and genomics colleagues, surgeons, nursing and allied healthcare professionals, and also obtaining the sort of specialist advice from our medical colleagues in terms of managing some of the novel toxicities of the treatments I've discussed. So thank you very much for listening, and I'm very happy to take any questions.
Thank you very much, Andrew. That was a very informative talk. Any questions? If you want to raise your hands, let's just see who is there.
Shema.
Shema, do you want to put your camera on and ask your question?
Hi, yeah, sorry, I don't have a camera, but thank you so much for such a good talk, highlighting all the advances in systemic treatments. I just wanted to ask whether this has changed how you follow up patients, because I know there's a lot of patient-initiated follow-up for people with endometrial cancer, and now that we have more treatments coming out, has that changed sort of in terms of imaging and how you follow up the patients?
So those changes haven't really had an impact yet on our follow-up practice for patients. I mean, we generally use patient-initiated follow-up for those patients who are at very low risk of disease recurrence. And we know from trials that have been done previously, admittedly not in the area of targeted therapies, that conducting sort of regular imaging in that patient group wasn't associated with improvement in detecting recurrences or overall survival. I think where it has changed is in my management of patients with advanced and recurrent disease. So particularly in those patients where we've been treating with standard of care chemotherapy, we are now monitoring those more closely with imaging. So if we do detect recurrence, we can move on with the targeted therapies that we've discussed today.
Any other comments? Any other questions, Anna?
Yeah, I just wondered, in terms of monitoring for immunotherapy side effects, do you have a sort of standard protocol with regards to blood imaging, or do you go on symptoms? Anything you do as standard?
Yeah, no. So I mean, we do have a routine panel of immunotherapy bloods that we test, and I'm sure all centres do that. So that would be a full blood count, biochemical profile, including LFTs, ALT. It's really important as well to check thyroid function. As I said, about 10% of patients will develop abnormalities in thyroid function, particularly hypothyroidism on treatment, and also to check cortisol, because one of the things that we really get very worried about is immunotherapy associated adrenal insufficiency. And again, it's very important to educate your patients so they're aware of the potential side effects of treatment, particularly things like breathlessness and diarrhea, which may require rapid commencement of steroids if the patient has a colitis or a pneumonitis.
Fantastic, thank you.